Good morning everyone, my name is Ellinor and my talk today is about weight and pregnancy. Before I start, I just want to say thank you very much for the invitation to your organising team. You're a bit all over the room. I'm very, very delighted to be here, and I have to say I had a fantastic discussion just this morning in my group. I hope you all had the same. I'm looking forward to the discussion for the rest of the day. So, as I said, we're talking about pregnancy and weight. And when we talk about pregnancy and weight, we're talking about two different things. We're talking about maternal obesity, or the weight that women start pregnancy with, whether that's a healthy weight, overweight, or obesity. And here I want to talk about some of the prevalence, specifically to Ireland, some of the health risks associated with maternal obesity, and then some of the ideas for prevention. My second part of my presentation is going to be about gestational weight gain. This is the weight that women gain during pregnancy. Again, start talking about the prevalence, then some of the health risks associated with this, both for mum and for the baby, and then some suggestions for intervention development.
Sorry, Ellinor.
Yes.
Just move closer to the
Bit
microphone.
closer.
In, please, if possible, just into the rows, because it's really hard to get the sound right. Unfortunately, the mic. It's very hard to hear
sorry.
at the back,
Yeah.
but
No,
it
it's
will
not,
help
it's just
if
a room.
you move in slightly in the rows.
Sorry.
Sorry, yeah.
No, it's fine. Okay, so I'll try again. Everyone at the back, can you hear me? Okay. Can you hear me? Yes, in the back. Yes? No?
Can hear you already.
So the middle people can hear me, not quite at the back yet. Do you want me to be any closer to the mic? Is this better? Okay, I'll try not to move very much then. Okay. So this is the presentation outline for my presentation. Oh. And there's my first slide. Prevalence of maternal obesity. Well, this is data from Ireland, from a big hospital in Dublin, so very local data from a few years ago, suggesting that about 17% of women start pregnancy classified as obese, have a BMI over 30. That means if you're a midwife and you have 6 appointments in one day, one of those appointments is going to be with a woman who have a BMI over 30. In addition, about 30% of women are going to start their pregnancy overweight. So I think with Phil Jennings' numbers this morning, that's approximately 34,000 women per year are starting pregnancy overweight or obese in Ireland. Why are we concerned about this? Well, there are numerous health risks associated with maternal obesity. What we did a few years ago was a review of reviews looking at these health outcomes. We're comparing a healthy weight woman with a woman with a raised BMI, so BMI over 30. And what we found was women with the raised BMI had higher risks of gestational diabetes, hypertension, preeclampsia, cesarean sections. I can go on. So high risks associated with maternal obesity. Not just for mum, also for the baby. So we looked at infant birth weight, and what we found was that women with maternal obesity, they have a decreased risk of low birth weight. That's actually a good thing. We don't want children to be born not weighing enough. However, we also found there was an increased risk of high birth weight. In other words, maternal obesity is associated with high birth weight, i.e. the children being born heavier than they should do. So, what could we potentially do about this? Well, a few suggestions. We clearly need to act in preconception. So before women become pregnant, we need to act. We need to inform them that maternal obesity is associated with health risks. How do we do this? Well, the problem we're having here is that there's a lot of women in the preconception period, and very few of them actually seek healthcare professional advice. So this study from last year, it was done in London, the UK, and they found about 1/3 of women actually seek preconception advice. So we can't just rely on this primary healthcare to do this. We have to think broader than that. In terms of what we can do, well, again, a recent Cochrane review found no interventions to date looking at decreasing weight in women before pregnancy and then and looking at the pregnancy outcomes afterwards. So clearly, a lot of research is still needed regarding how to act in the preconception period. There is a trick, though. The trick is into pregnancy. So think about it. The first women have a baby, then in the postpartum period, that's also, you can argue, their conception period, because they're thinking about potentially about having a second child. So data, again from Ireland, this is again done in Dublin Hospital. They had a baby, the mums had a baby at 2009 and they were weighed then. They had a subsequent baby in 2012, were weighed then. What this research found was that 64.6%, about 2/3, had gained weight between the first pregnancy and the second pregnancy. This is also where we have to intervene. So they're in preconception period, but also sort of in the postpartum period, so a bit of both. We call it into pregnancy just to confuse you, essentially. How can we do this in terms of postpartum? Well, a review by Van der Pluyt and colleagues in 2013, they found that interventions including both healthy eating and physical activity were the most successful in helping women to lose weight postpartum. However, and this was done in 2013, and still things valid today, we're still waiting. We still don't know exactly what the optimal setting is for these kind of interventions. When do they start after having a baby? What is the delivery mechanisms there? And then how long do these interventions, how long should they be? So again, more research is needed in the postpartum phase in terms of helping women to lose weight afterwards, after pregnancy. Now, that's all I wanted to say about the maternal obesity. The second issue is gestational weight gain. So here we have a table. It's an American table from Institute of Medicine from 2009. And as you can see, I'm going to try to use this. Oh, excellent. If you have, depending on your weight category, when you start pregnancy, this is how much weight you should gain. So if you have BMI over 30, then they recommend about 5 to 9 kilos or 11 to 20 pounds throughout your pregnancy. And if you gain more than these recommended guidelines, you're said to have gained excessive amounts of weight in pregnancy, so excessive gestational weight gain. Excessive gestational weight gain is associated with a number of health risks. So first, let me tell you about the prevalence, then tell me about the risks. So a fairly recent study, this is a UK study, found that between 40 and 60% of women gain more than the recommended guidelines. This is very similar to data from Ireland as well. In fact, in the Irish study I'm thinking of, about 80% of the women who were overweight starting pregnancy gained too much weight during pregnancy. So this is clearly an issue. This study I've mentioned here is from the Postman's group. They found that women with obesity, they gain about 7 kilos in the pregnancy, and obviously that is within the guidelines, but as you can see with the standard deviation being 4, there will be women that gain less and more of that guideline. But in the Irish study, I'm sorry I don't have that on my slides, the Irish study, here et al., I think it's in the Public Health Journal, I can't remember which one, apologies again, they found that women with obesity gained about 12 kilos during pregnancy. Okay, so that's a lot more than 5 to 9 kilos that is recommended. What are the health risks associated with this? Well, increased risk, again, preeclampsia, cesarean delivery, gestation diabetes, but also, again, not just for mum, but for baby. So here, data from the Southampton Women's Survey a few years ago, they found that women who gain more than they should, and that's defined by the guidelines, their children then started life heavier. So they had a 7% higher fat mass at birth, and then, as you can see, that continued through 4 years and 6 years. So clearly, we need an intervention. How should we do this? Well, role of the randomised control trial comes to mind. It is an Irish study. It was done a few years ago. I think there's some follow-up data on this study on the posters, so please make sure you look at those later. It's quite a big randomised control trial, and they tested a low glycemic index diet compared to routine antenatal care, and what they found was there was no effect on birth weight at delivery, and that was the primary outcome. We have a second study, this is an upbeat study from England from a few years ago. Almost 1,300 women with maternal obesity were recruited. It was a physical activity and healthy eating intervention. And what they found again, no difference in gestational diabetes prevalence, that was the primary outcome, and the neonatal outcome was birth weight. Again, no difference. So clearly, we don't quite yet have the evidence to suggest that gestational weight gain alone will change on the birth weight of children. However, my argument would be that these changes, although there were significant differences in the gestational weight gain between the groups, those changes were within the kilo. So they probably weren't enough to actually have an effect on birth weight. So I still want to argue that we need to focus on gestational weight gain, and the reason is this. Think about the weight trajectory from pregnancy to postpartum. Again, Irish research. 90% of those women who were classified as obese in early pregnancy also classified as obese at 4 months and 9 months postpartum. Women gain weight in pregnancy and they struggle to lose it afterwards. Excessive gestational weight gain, so gaining more than the recommended guidelines, are associated with increased odds at overweight and obesity, not just in the first year, but up to 21 years later. And this is data from Australia. So clearly, it's the time period, if you look at the lifespan, where women gain weight, but they didn't actually manage to lose the weight afterwards. So what can we do about it? Well, I have a few suggestions for developing interventions. The first thing I want to say, and this is going to be my main message for today, is we have to put gestational weight gain on the agenda. Women need to be aware that gaining too much weight in pregnancy will be associated with health risks for the mum and for the baby. I don't think women are aware of that today. So what we find a lot in literature, and this is highlighted by my quote there to the left, don't worry about your weight, you can lose it afterwards. That's a lot of women believe that. That's not necessarily true. And this second quote, and this is probably my favourite quote of all the research I've done to date. This woman, she's a pregnant woman participant, and she's talking about gestational weight gain. And she's saying, so in my opinion, it's not something that's that important. If my midwife doesn't need to check it, because she checks the important things. So how we put gestational weight gain on the agenda is to enable and equip healthcare professionals, midwives come to mind as one of the primary key professionals in this, to actually mention weight to women. How can we do this? Well, some suggestion is, and then again, I'm going to be even bolder and go, we need to consider reintroducing weighing women in pregnancy. Weighing women in pregnancy is a gateway to then introduce discussion on gestational weight, is introduction, we can gateway to talk about healthy eating, it's a gateway to talk about physical activity and reducing sedentary behaviour. In terms of whether this is feasible or not, well, a feasibility study from a few years ago in England found that it was feasible. The midwives did not find it was an additional task for them to do. And this routine weighing in appointments took between 1 and 2 minutes. That's not a lot of time to actually making sure that women hopefully feel more equipped to gain a healthy weight in pregnancy. Again, data from Ireland, finding that Irish women report that they actually would welcome being weighed regularly in pregnancy. They found it reassuring, and they also were aware that they are going to be heavier postpartum, and hopefully helping them gain a healthy weight during pregnancy is then going to help them postpartum as well. So this is actually a welcome thing from women, and this is just one study. It's been found again and again in other countries. So the second thing I want to talk about is we need to support midwives. They've been the key key target here. They need to support them to refer women to weight management services, okay? Just weighing women in pregnancy is not going to be in itself. It's going to be the catalyst to then able to refer women to weight management services. I've been involved in a study recently where we interviewed women, midwives, who refer women to weight management services in pregnancy, and they found that they need information about the service. Where is it? When is it? Who is it for? Those are the key aspects of it. They also want reminders, regular reminders. This is a service. This is still happening in the community. That was also very important to them. But thirdly, also feedback on referral. They want to know who have actually taken up the service and who has not taken up the service. In terms of developing interventions, well, research has to date suggested that dietary interventions seem to reduce maternal gestational weight gain. My argument as a keen enthusiast of physical activity would be that I don't think there's enough focus on physical activity at the moment in pregnancy. I don't think women are equipped to actually engage with it enough. That's why we probably don't see the evidence or the effect of physical activity in our interventions, because women don't actually engage with it enough. So don't go up on physical activity, but yes, dietary is definitely important in these services. So then, last few slides, how can we develop these services? Well, we interviewed women who have engaged in this weight management services, both during and after pregnancy. One of the key things that came out was, especially postpartum, they want help with weaning. They want help to actually tell the children about healthy eating and being physically active. They want the family-focused perspective. That seems to be very, very important. Services that have home visits, women really like the home visits. Equally, when we have group community care services, they like that group community care. Goal setting seems to be very, very popular, and they find that really helpful to have them to actually focus on the behaviours and that they need to change. And then the physical activity support. As I said, in pregnancy is very important, but also postpartum, what activities can you do after you've had a baby? Aspects to avoid were information provision without actually any support regarding how to do it or opportunities to do it, but just in information, just the healthy recipes, that's just not enough for any behaviour change. Women also didn't like inconsistent services, and this is something we talked about in my group this morning about how services are there in a moment and then they just disappear the next. We have to have services and we have to make sure they run a long time so women can actually build rapport with these types of services. And then thirdly, they did not like not including partners. So again, that family-focused aspect of intervention seems to be very important. Okay, so we also did was we interviewed women who said no to our weight management services. At first, we were quite disappointed that they said no, but we got over that and interviewed them and asked them why. And what they said was they was very heavily about the unclear referral. They did not know why they were referred to a service. So they compared, pregnant women, they compare notes. And when you refer to something, but your friends are not referred to something, and that's because of your weight, that's when we're creating weight stigma. So we have to be very clear about why women are referred to a service and what the service actually entails. Secondly, women say they don't need support, physical activity, healthy eating, they can do that without support. And then thirdly, it was like this, you're damned if you do, damned if you don't. This inconvenient time, inconvenient place. If you have community groups, there's always going to be some participants say, that's too far away from me, or I can't do that time, or I can't do that weekday, for example. So then, to conclude, I've talked about maternal obesity and gestational weight gain this morning. The key message really here is that we need to focus both on preconception period. Let's not forget about the postpartum period that can also be seen as a preconception period, but also most importantly, let's focus on pregnancy. Let's put gestational weight gain on the agenda for pregnancy so women are informed about what healthy weight is and also help them, equip them through help of midwives, actually equip them to do something about their weight. Thank you very much.